Good morning.
How are you doing?
Iko salama kabisa.
Iko salama kabisa.
Yes.
Good to have you here again.
Thank you. It's always a pleasure to come back. Yes.
Thank you for doing it. And we are getting into an issue that has a lot of people shedding tears, but interestingly enough, at the end of it, has a lot of people who are also smiling and enjoy.
Absolutely.
So we're going to look at both ends of the spectrum today.
Exactly.
But before we do that, we're in a different country this month, and you know what we're going to do? This week, rather. Dennis is going to share today's proverb.
Yes.
I'll tell you where it's from. We'd love to hear interpretation.
So today we're from Rwanda, home of Africa's, one of Africa's Great Lakes, Lake Kivu, and a population of around 13 million people, and one of the cleanest country, not only in Africa, but the world. And the proverb of the day from Rwanda: a tree planted by God is not uprooted by the wind. A tree planted by God is not uprooted by the wind. How would you interpret that?
Wow. I was actually there 2 weeks ago. My wife comes from Rwanda.
Oh, how about that?
And I've traveled a little bit in Rwanda. It's a beautiful country. I urge my countrymen to visit it from time to time. Now, a tree planted by God is not uprooted by
The wind.
It means, in my understanding, that there are things which are deeply inculcated or can be deeply inculcated in a person. And here, when we talk about God, I suppose these are spiritual matters. And when they're deeply inculcated in us, just like what in Psalms 1 says, that a tree planted by the rivers of waters will always bring its fruit in its season. And just like a man who does that, who is planted in God, whatever he does will prosper. And even if there are going to be challenges in life, he will be able to survive. So I think that is my take of it. And I think it urges us to have a deep spiritual grounding in God, and such that whatever other problems that may come with life, which is a natural thing, we will always be able to survive and manage.
Indeed. Fantastic. This month of June is World Infertility Awareness Month.
Correct.
And today, as we have the conversation, I imagine that as we sit in this room and talk about it, there are many people who sit in other rooms who are wondering when and how they can have a child. Because
Correct.
that is exactly what we are discussing this morning.
Absolutely, yes.
When we talk about infertility, and I would love you to give the definition, because, you know, I could do my own thing, but I could be way off. Let's look into it this morning. So when we just start with a broad and as detailed as we can, I guess.
As detailed as we can.
When we talk about infertility.
Let me start by just giving you a small story before we go into the definitions. Not too long ago, I used to run a clinic and an IVF center in one of the hospitals in Nairobi. And on this particular day, I arrived a little bit late because I'd been caught up with some other work in KNH. So I arrived and there was a gentleman who was very annoyed, you know. There was a long queue of patients and he was one of the patients. And he was very agitated. Of course, I apologized. I said, I'm very sorry for coming late, but it's because I had been caught up elsewhere, but I'll see all of you. And unfortunately, he was the last person in the queue. So I sorted out all the other clients, and then he entered the consultation room and very unceremoniously threw a piece of paper onto the table. My principle is that I don't look at any tests. I listen to the story first and then I come and look at other tests. So I took the history of this gentleman. Some of the questions that we ask is whether he's married. He was married. He was actually in his second marriage.
Okay.
And he had children. With the first marriage, he had 4 children. With the second marriage, the second wife came with a baby, but she was expecting 6 months. So, again, he had 4 children from a first marriage. He is in a second marriage. The second wife came with a baby, but he was expecting 6 months. It did not make sense to me. So in my mind, I'm asking myself, so why did you come to see a fertility specialist? So anyway, I put that in the parking lot and we went through all the other questions. And then I asked, how can I help you? And then he pointed at the piece of paper, which I took. I looked at it. These were the results of a sperm test, a sperm analysis. And he had no sperms at all. He had what we call azoospermia, no sperms. So I asked, if you have children and your second wife is expectant, why did you go and do a sperm test? He said, I used to be in a relationship very many years ago. And when they broke up, this lady told me that I was infertile. So I decided to go and do a test on my own, which came back as being negative, meaning no sperms at all. So I explained to him, I said, probably there could have been a problem with the lab and so on and so forth. So why don't you do another test, a fresh test? Very diligently, he did a test. And the following Monday, I used to have that clinic on Mondays. The following Monday, he was there. And the test showed the same thing.
Okay.
He had azoospermia. No sperm at all. So let us try and find out where the problem is. Now, remember, he has 4 children from a first marriage. His second wife is expectant, 6 months. So in essence...
And she came with a baby.
And she came with a baby. So his babies, quote unquote, are how many? 5. Aligongewa mara ngapi? Mara tano.
Oh, okay. Especially if he's got azoospermia, okay.
He has azoospermia.
Yeah.
But he has 4 children from somebody else, another wife,
Yeah.
and his second wife is expectant, 6 months. So I sent him for some tests, some blood tests, and another to do what we call a scrotal scan to look at the testicles and so on. So the results come back. The testicles were tiny, what we call hypoplastic, meaning they are smaller than they're supposed to be, and probably not productive. However, the blood test results, when they came back, because we checked hormone levels, and 2 or 3 of his hormone levels were very high. What did that mean? It meant basically that this guy was not producing sperm from a long time ago. So I explained to him and I told him, most probably your problem is here, is hormone levels, and that is why you don't have sperm. He said, is there another test that I can do? I said, yes, of course, there is one that you can do, and that is what you call a testicular biopsy, meaning we take some small tissues from the testicles and they are analyzed under microscope. You can actually see the development, what you call spermatogenesis, development of sperm. And it has several layers or several levels. And what the results showed was that this guy had never produced sperm at all. So an awatoto one from somebody else, and the present wife is expectant 6 months.
Okay.
So aligongewa mara tano.
For sure.
So, so we had come to the end of the road in terms of diagnosis. And of course, I knew where the problem was, and I explained it to him. And then he asked me, so whose are these children? I said, well, I can't answer that question. And are there some other extra tests that we can do? I said, actually, we've come to the end of the road. So I could see his dilemma. And I tried to sort of soften the blow by saying, there are 2 types of fatherhood. The first one is you are the genetic father. You give the biological material. And then there's the social father, the one who takes care of these children after they are born. It is good, or it would be good, if you are both the genetic and the social father, because then, you sort of, this is a 360 sort of care. But in this case, you are the social father, because these children only know you. You're the one who's been taking care of them, paying their school fees, feeding them, etc. I could see he was very, very troubled, and I asked whether I could organize for some therapy for him, counseling, and he said yes, he wanted to talk to somebody. I did organize for counseling for him, but unfortunately, I never saw him again. I don't know what happened to him. He could be out there, hopefully.
So he represents a number of people. And when we talk about, for the longest time, when we looked at issues of infertility,
Correct.
that usually this landed at the doorstep of women.
Absolutely.
And why was that at that time?
Actually, it is still the same even now. It has
Okay.
not changed.
Okay.
And the reason is that women are the ones who manifest what has been happening behind doors. So if after getting married, and in most weddings where you attend, you say, we wish you to have children, and your parents tell you, we want to have grandchildren as soon as possible, get on to it, and we want to be called grandparents. So if it doesn't happen and the woman does not show a bulging abdomen, then the problem is hers.
Yes.
So that is why the brunt of the issue of the problem of infertility is actually apportioned to women, whereas actually statistics show something completely different. Infertility affects men slightly more than women. About 40% of the issues of infertility are actually caused by men, or a male factor, as we call it. About 35% are women, or female factor. About 10-15% are both. And then we have a small percentage where it is quote-unquote unknown. What does that mean? It means that we have done the basic tests and we still can't find a reason why this couple is not having a baby.
So the larger percentage, is with?
Is with us men.
Is with men.
But you
okay.
see, men, we say mbele iko sawa.
Yeah.
So long as you are able to to come to attention, as it were, then you are okay.
You assume you're fine.
We
Okay.
assume you're fine. And then the other myth, which is very wrong, is that we think that as a man, as long as you can be able to ejaculate, then you are fine. But that is not true. You can ejaculate and still be not fine.
So, with all this information that you've just packed in, one would just ask this simple question: what are the causes?
Thank you. The causes can be both male or female. But before we even go there, let me start by defining what you had asked me to define right at the beginning. What is infertility? There is what we call primary infertility and secondary infertility. When you talk about primary infertility, we talk about a couple who are in a relationship, and this is a lady and a gentleman who are in a relationship, who have intercourse 2 to 3 times a week, and a year has passed and there is no conception.
Okay.
Now, secondary infertility is where, yes, again, the same...
Unprotected.
Unprotected, yes, unprotected.
Yeah.
And in secondary infertility, of course, the same principles apply. You are is a couple, a heterosexual couple in a relationship, having intercourse 2 to 3 times a week, and but they have had a conception in the past, or they have a baby or babies. Now they're trying to have another baby, and it hasn't happened. And the caveat here is that the woman is not breastfeeding, because breastfeeding can actually act like contraception if it is regular. However, there is a caveat to the primary and the secondary infertility as well, where the age of the patient, of the lady especially, when it is a lady who is 35 years or more, we shorten that time of 1 year to 6 months. So if it's a patient who is 36, for example, and she is in a relationship and 6 months, nothing has happened and everything is deemed to be okay, then we can actually consider that to be a reason for them to start the process of trying to find out what the cause of infertility is, and then from there, of course, to treat the cause or the causes. Okay. Talking about the causes of infertility, let me start with ladies first. Age is one of the biggest factors. And what age are we talking about? We are talking about 35 years or more. And why is age a factor? It is a factor because ladies are born with a set number of eggs. And this number decreases every time ladies have a period. So if they start having periods around 13, 14 years, and then you're coming at 35, 36, so you've had 20-something years of loss of eggs, as it were. It doesn't mean that this number completely goes to zero. Is that the longer you stay without having a baby, that ovarian reserve decreases, number one, and then number two, the quality of those eggs actually decreases with time, which is a natural process, because as we grow older, we age, and then there are some processes, which will go sideways, as it were. So age is a factor. Now, age is a factor, and I'm seeing that not only in our country and even where I was practicing in the UK, because you find when ladies go to school, especially in some of these fields, when you finish when they finish school, they go to primary, secondary, university, and some of these courses take a little bit longer. So by the time they finish these courses and they start now working professionally, and they start, rising up in the professional ladder, as it were. By the time you get to the top of the ladder, as it were, you find time has gone, and even those gentlemen who are hitting on you when you are, in school, you find, and you didn't even look at them because you look at that shoe and say, what is he going to offer me? That sort of thing, and you move on. So by the time now you think, or ladies think that now I have everything, and now I need to settle down, you find there are no gentlemen who are ready to settle down with you, or the ones who are willing to settle down with you have a lot of baggage, and now age has also caught up with you. So infertility, low number of eggs, poor quality of eggs, and then because of that, the chances of that, even if we were to do IVF, you find the embryos that we create are poor quality, and then chances of implantation and having a baby become a challenge. What I'm seeing in this part of the world as one of the biggest challenges is actually an issue with blocked tubes. If you remember a little bit about biology, during ovulation, one egg is released either from the right or from the left side, and this egg is picked up by the fallopian tubes. And as it's picked up, it's actually because of movements, what you call peristaltic movement. This egg is pushed into the fallopian tube, and during that ovulation time, when a lady has intercourse, and assuming that everybody is okay with everything is okay with the gentleman releases his sperm around the cervix, and the sperms swim through the cervix and into the womb, and they get directed to which side they're supposed to go to. When I end up this is the way you go to. They actually directed to the side where ovulation did occur. Now they go through that tube and they reach a place where a very particular place. The Bible talks about we are wonderfully and fearfully made. It is actually very true, because the egg and the sperm meet at a particular point in the fallopian tube, and there is a cloud of millions of sperm which swim around that egg, and it's only one sperm which is actually able to penetrate that egg. And even as it penetrates, it's a very intricate mechanism. It releases a small amount of acid which drills a tiny hole, and as it drills that tiny hole, the sperm has a layer. It's kama kofia. Inatoa hiyo kofia, and then the genetic material gets into the egg, and fertilization occurs. As it has occurred, the fertilization occurs on the first day. And the second day, they started dividing. That embryo starts dividing and starts being pushed back into the womb for implantation. If the tubes are not working, if the tubes are blocked, for example, if the tubes are stuck to the pelvic side walls, for example, if the tube has fluid in them, or if there are no tubes because of surgeries and so on, of course, this natural process is going to be a problem. The bulk of the patients that I see, and I think I've had a discussion with some of my colleagues, this is one of the biggest problems we are having in the so-called developing world. They are young patients who are able to do everything, but their tubes are blocked. Why? Because of sexually transmitted infections, especially chlamydia. Chlamydia is an infection which has no symptoms at all. The patients are asymptomatic. It affects the gentlemen. It also affects the women. It blocks the tubes, or it makes the tubes, get stuck to the pelvic side walls, and the tubes will not be functioning. For the men, it also blocks the tubes where the sperms pass through. So there will be an ejaculate, yes, but that will be just seminal fluid, but there'll be no sperms because of that blockage. Okay. Now, we have fibroids, which is a big problem in this part of the world. I can see Princess is smiling a bit about fibroids.
Yeah, another, okay.
About 30 to 60% of women of reproductive age, especially of African origin, whether they're in Kenya, whatever, will have problems with fibroids. We don't exactly know why. And then our women have, the number of fibroids they normally have is more than if you compare it to other races. The sizes of the fibroids are also very big. I have removed a 6 kilogram fibroid. My colleague removed 140 fibroids from a lady, and he managed to preserve the womb.
Wow.
So fibroids is a challenge. Why is it a challenge? Because number one, it can distort the cavity, and that is where the baby implants. Number two, it can also lead to the blockage of the tubes as well. Number three, if it is what we call submucosal, meaning just below the surface of the lining of the womb, it will be an impediment for the embryo to implant, because it will look like, remember, the embryo is tiny, you cannot actually see it. Even under microscope, you have to do a lot of magnification in order for you to be able to see it. So for that embryo, for that baby, as it were, quote unquote, and if there is even if it's half a centimeter, for it, it's like Mount Kenya. In order for it to find a place where it can actually implant. So and then we have problems, not in any particular order. We have problems with hormone, what we call hormonal imbalance, where the thyroid hormones can be elevated. Sometimes what we call prolactin, which is a hormone which makes the breast produce milk when a woman is expectant, can be all over the place. We have issues with polycystic ovarian syndrome. We have issues with endometriosis. We have issues with lack of intercourse. We have issues with lifestyle, what we eat, and so on. So all this together, sometimes you have one issue, sometimes you have several of these issues together, and then so on. Something else which actually is also a challenge is stress. Psychological stress. So you find you've been trying for X number of years to have children, and it has not happened, and it is quote unquote unknown. And then you forget about it, and then all of a sudden, you get pregnant, and we see such cases. Then later on, you have 3 other children, and so on. But we cannot quantify what amount of stress can actually lead to infertility. When it comes to men, we have challenges. Now, the biggest problem is the quality of the sperm. Okay. So you may have, number one, that content, that the volume of the fluid is not enough. We normally need actually a very small amount, 1.5 milliliters. Yeah. 1.5 milliliters is not even a teaspoon, not even half a teaspoon of fluid. But in that half a teaspoon or whatever it is, you have millions, sometimes millions of sperm. So the volume can be less than what we expect. The number of sperm in 1 milliliter can also be low. You may also have that the total number of sperm, actually we need 40 million, just that.
To do what?
Just 40 million. When you have 40 million in a sperm analysis, it means it is okay.
Okay, that means you're fine.
It is okay. It is okay. Now, the way the sperms move is also something which is very important. Now, there are different types of movement. There is type A, type B, type C, and type D. Now, the type A or type 1 are the ones which move very fast, and they have a direction. Let's call them the sprinters. So type 1 are the sprinters. Type 2 are the long distance runners, the Kenyans hapo. So we normally put the sprinters and the long distance runners together, and we need 40% or more. Type C, we don't even count it, because type C, these are the ones which move but are in one place. So they are going round and round. Ni kama zimelewa. Hizo hatushughuliki nazo. And then type D, these are the ones which are immotile. We don't look at them. And then we also look now, out of all these numbers, how many of them are actually okay, what we call morphology. We only need 4%. So, for example, if you have 100 million sperms, 10% would be 10 million. So 1% would be 1 million. So 4% would be only 4 million. So out of 100 million, we only need 4 million to be okay. And then we know that the chances of, this couple having a baby is normal. Okay. Now, we also have issues with this sperm not being there, like the case that I mentioned to you, lack of sperm completely. There is what you call necrospermia, where all the sperms are dead. You may have sperms, instead of the sperms coming out during ejaculation, they actually go back into the bladder, what you call retrograde ejaculation. We have issues with erectile dysfunction. Good morning, gentlemen.
Good morning.
Good morning. and unfortunately, this is an issue which touches on old. I don't want to call them older men, but slightly mature men.
Okay.
Usually in the 50s plus, and there are other issues which may accompany this. For example, other diseases like diabetes, like hypertension, and so on. But it has been noted that younger men are also having this challenge
Okay.
in the 20s, 28, 29, 30s, and so on.
And so on.
We have.
I want to take a break at this point.
Yes.
Because then we can go into then what, to do about it.
Correct.
Right? We're looking into World Infertility Awareness Month, and we're looking around infertility issues. I mean, and just from this, there's a plethora of issues that folks obviously suffering from. Dr. Kireki Omanwa is here with us this morning, and we're going to come and look into, okay, fine, these that he's mentioned are some of the issues that you may have. How do we fix it? We'll be back after this. It's the Situation Room. From the man and the woman. But then the question is, what, from these issues that you've talked about, what would get to the point whereby we say absolutely nothing can be done about it? You will not have a pregnancy, and then go to now some of the interventions that we see coming about later, like, IVF and others.
Thank you. The most important thing is to listen to the patients or to the couple, as it were. And by the way, we actually encourage the couple to come together. But most of the time is the ladies who come alone. Wameambiwa na mzee, enda kwanza, uangaliwe, and then unilete report. So once we do that, we finish with the lady, and then we tell her, okay, now please bring the gentleman along. So after taking the history, most of the time you sort of have an idea where the problem could be. If they have heavy periods, for example, and with clots and so on, you may think about, fibroids, you may think about what you call uterine polyps, and so on. And for the ladies, it's a little bit, I don't want to say it's complicated, but we do more tests on the ladies than on the gentlemen. For the ladies, once we've taken the history, we want them to do what you call an HSG, hysterosalpingogram. What does that mean? It means we send them to radiologists, and they do, quote unquote, a scan. A small instrument is inserted in the cervix, and then contrast is injected into the womb, and the radiologist take pictures, X-ray pictures. This will help us see whether the uterus is okay, number one, and number two, whether the tubes are okay. So that is a very basic thing that we need to do for ladies. Number two, we need to do a blood test to look at 3 hormones. That is what you call TSH, to see whether the thyroid gland is working well. And the thyroid gland produces a hormone which is very, very important, which you can, quote unquote, call a manager of other hormones. If the thyroid gland is not working well, it will affect the whole body. So we need to know that. And then number 3, we also need to do what you call a prolactin, a hormone called prolactin level test. And prolactin, sometimes if prolactin is elevated, even if the lady is not expectant, she will not get pregnant, even though everything else could be okay, because the body thinks, quote unquote, that it is pregnant, it is expectant. So if a lady is expectant, she cannot get pregnant. So we need to check that level. And then we also want to see the ovarian reserve, what you call AMH. So that is a blood test. So you do an AMH, prolactin, and TSH. And then we also want to do a transvaginal scan. The role of the transvaginal scan is basically to look at the ovaries, and we actually count what we call antral follicles. We count the tiny follicles, which, were we to start treatment straight away, these are the ones which would grow. So we need to count that, number one. Number two, we also need to look at the womb itself, and also look at what we call the lining, if there are any issues there. So we'll have done away with the test for the lady. For the gentleman, it's very simple. even though it's not very simple as well. we need them to do a sperm test. So we give them a request to go to the lab, and we request them not to have intercourse for anywhere between three to 5 days to a week, and then they can go and give a sample. Most of the time, 99.9%, this is done through masturbation. Though most of the time when you talk to the gentleman, they say, "Hii kitu unatoa namna gani?" So when you explain to them and say, "No, that is
We're
an
not gonna do
African.
that, yes.
Yes, we can't do it," and so on and so forth. And we can actually suggest that he goes with his wife to help him. Waende wajifungie, and then and then they give the sample. Now, sometimes they may have a blockage completely that we can't be able to do this. There is a small chance, or there is a chance whereby they can use a special condom, silicone condom, which they can have intercourse, and then they remove the condom, put it in a container, and bring the sample to the lab. We normally suggest that this sample is collected in the lab because time is of the essence, and then the temperature. Outside temperature is also very important because we know if this is done at home and you are maybe 1 hour away, by the time you get to the clinic, that external temperature will have affected the sample, and it will affect the outcome. So we suggest that this sample, if it is going to be collected at home, the time interval should be less than an hour, about 45 minutes on the outside. Number one. Number two, if it is possible, let the lady carry it and wrap it nicely, and then put it between the breasts because of temperature, and then she brings it to the lab.
Okay.
Men would put it in the pocket and they'd be whistling, to bring it there. And of course, by the time they get there, it will have been affected.
Okay.
Now, once we've done the tests, we normally have an idea where we are going. We did a scan, and with the scan, we found their fibroids, for example. How big are they? Where are they located? We can do, treatment of the fibroids, whether it is open surgery, laparoscopic surgery, whether it's HIFU or whatever it is, we can sort that out. If it is an issue with endometriosis, for example, we can treat the endometriosis, put them on the medications, and then come back after some time. If it is polycystic ovarian syndrome, for example, we also sort it out. The tubes is a challenge. Sometimes we do what is called tuboplasty, trying to open the tubes. It's not a very promising sort of procedure, because most of the time when you do tuboplasty and you open the tubes, there's a healing process which starts after the surgery. The tubes get stuck again. So you'll have actually gone back to zero, as it were. So most of the time, personally, I don't encourage tuboplasty, because we will be exposing this patient to all manners of surgery, and then still we will not have helped her at the end of the road. So in such cases, I propose that we think about another way of treatment, of circumventing the issue of tubes.
Okay.
If it is on the male side, we look at those numbers, we look at the motility, we look at the numbers, we look at the volume, and we normally, if there is an issue with the numbers or the issue with the motility, we normally put them on medications, and usually for anywhere between 2.5 to 3 months, because the normal production cycle of sperm is usually 2.5 to 3 months, and then we recheck. We do a recheck of the sperm test, and if everything is okay, then now we can propose what methods of treatment. And the methods of treatment are actually quite a number. If this is a small issue with the sperm, once you've corrected that and the lady is fine, there are no problems, then we encourage them to have intercourse, what we call timed sexual intercourse, but we can do what is called follicle tracking, meaning we do a scan, we see where this patient is going to ovulate from, and then we can actually give this lady an injection, and we know that once you're given that injection, 24 to 36 hours she's going to ovulate. So we tell the gentleman, utakuwa na kazi nyumbani, so ambia boss hautaenda kazini because you work at home to do, and they do that. If age is not a factor, we allow them to try it for 3 to even up to 6 months. If it hasn't happened, we can can go to the next step, which is called IUI, intrauterine insemination, and where we prepare the lady again. We monitor where she's going to ovulate from. We give her an injection, and then on the day that after 24 to 36 hours, they come together to the clinic, and the man gives a sample. We clean it, and then we inject the sperm into the womb, and then we wish them all the best. Now, if there are issues with the tubes, for example, or there are issues with the low number of the number of eggs is not very good, and so on, we suggest that they consider IVF, or sometimes even after trying to correct the gentleman, and still the numbers are not very good, then we can actually suggest what we call IVF. IVF is generic.
Okay,
basically.
sorry. What's when you talked about intrauterine
insemination?
It's different significantly from IVF.
Oh yes, it is.
Okay.
Oh yes, it is.
So in this intrauterine
Insemination, yes.
essentially you're bypassing a process, and at the end you're just putting in the final product.
Essentially what we are doing, remember there are 100 million sperms which are there, and only 4 million are okay. So we have 96 million which are not okay. So essentially what we are doing, we are actually taking that sample, removing all the sperms which are not okay.
Yeah.
And such that when we transfer or we inject the sperms into the womb, we are only injecting the best sperms out of that 100 million.
Okay.
So that is
this is after establishing that the infertility issue is with the man.
No,
And
this is we've established that it was an issue with the man. We have corrected it.
Yeah.
With the lady, there is no problem.
Right.
The tubes are fine.
Okay.
The hormones are fine. The uterus is fine, and the ovaries are fine. The
I'm sorry
number is
to
okay.
stick on this, because essentially what we're saying is that the correct sperm are not making their way for fertilization.
Correct.
So what you're doing is making sure that the correct sperm then are in the uterus for fertilization to take place.
For them to go and get to where they're supposed to get to.
Okay, fantastic.
Yeah.
Now, what's the difference between that
Yes.
and IVF?
Very good. Now, IVF is different, and IVF, well, basically, as I started saying, IVF is generic. We say in vitro fertilization, because remember, naturally, fertilization occurs in the tubes. Now, in vitro, it means this fertilization is going to occur in the lab, in a quote-unquote test tube. Now, again, the difference is that in intrauterine insemination, the lady may produce, usually ladies produce 1 egg. Sometimes you can give them medications. They may produce 2 eggs or 3 eggs, okay? And in IVF, we actually, on purpose, want her to produce as many eggs as possible.
Okay.
And we do this by giving her injections right from the beginning of the cycle. Day 2, day 1, day 2 of the cycle. And we give her injections for about 10 to 14 days. And as we're giving these injections, we are going to monitor how her ovaries are reacting to these medications, because then they will start producing, follicles. A follicle is what carries an egg, and we want her to produce as many follicles as possible. Sometimes they produce 10, 15, 20, 30, 30 eggs, as it were. Once we've established that the follicles are a good size, we take these patients to theater and collect the eggs. Once we've collected the eggs, on the day of egg collection is when the husband gives a sample as well. We clean that sample, and then now we take the sperm and literally inject 1 sperm into each egg, what you call ICSI. Or sometimes we take the egg and put it with a droplet of sperm, which has, those millions, and we let it, a natural fertilization to take place, but in a quote-unquote test tube. And we monitor how this fertilization has occurred and how this embryo now is developing. And after 3 to 5 days after fertilization, we take 2 or 3 embryos and we transfer them back into the womb. So in IUI, we send the sperms alone. In IVF, we transfer an embryo, which is basically the beginning of a baby. That is the difference.
Okay.
Doc, there is a question that has been asked here by one Kev Lubale, and it's all about men as well get affected by infertility. But then again, during the young years, I'm a teenager,
Yes.
size matters. And someone feels they are small, they decide to go for, if it's gel, they apply enlargement pills and whatnot. How would that affect the future life when it comes to fertilization and the entire process?
Well, when it comes to fertility, I really don't think size matters. See, Princess, you're looking up.
Yeah, because we just need from what you've said.
So long as the man is able to produce good quality sperm, size doesn't matter, in terms of fertility. In terms of satisfaction for the woman, that one, I'll leave that for another day. Now, the issue of enlargement of, and so on, my colleagues who are urologists have more information about this, but there are men who actually go and have, different things injected into the penis and so on and so forth. How does that affect? Remember, this is something which is intrusive, and this can lead to infections and so on. So with those infections now, in the process of quote-unquote trying to enlarge your manhood, you may actually bring on a secondary problem which can affect your fertility. So we have to be very careful about that. Yes.
And then there is this entire conversation. We understand that men pretty much, it's really rare for them to have this conversation. So one would ask the question, how do we bring men so that it's easy for them to have this conversation? Because you've said it, mama enda kwanza, later reporting nyumbani, yet they could be the ones having the problem.
Yeah.
So how do we create an environment where men, this goes to healthcare seeking behavior? How do we change that and how do we deal with that?
A very, very pertinent question, because ladies are wired differently. Ladies will meet at my reception in Frontline Medical Center. They will start talking and what has brought you here. Oh, I have seen, I've been here, these are the tests I've done, I saw so and so, but I heard my friend, was successful and so on. So they actually exchange this information very freely and without any inhibitions. And by the time they leave there, actually they become friends, and they can even exchange numbers, they can even form a WhatsApp group. Men, it's impossible. We are wired differently. We think that by sharing that I actually have a problem and I'm having erectile dysfunction, for example, I'm not able to, to come to attention, or I've not been able to impregnate my wife. And, men, sometimes we can joke with ourselves, hey, boss, ikazi, si tukusaidie, that sort of
it's
thing.
like you're weak.
Yani, what do you mean? Yeah. No man wants to be perceived as being weak. So we don't want to open up, especially in very intimate and very sensitive issues. So I think, can we form a support group? I'm not sure whether men will come for the support group. Women will, without at the drop of a hat.
They might even form one for the men.
That is true. But I think it's an issue of whereby having quote-unquote a safe space where we can actually discuss issues. The other, I think about a month ago from our church, we had a men's retreat weekend. It was fantastic because we are only men, about 30 of us, and we went and we discussed and we shared issues. You feel like we should have this thing more often, but women have it every week. They say, I'm going to have a chat with my friend, and they go, they have a tea there and they talk for 2 hours. By the time they finish, it's therapy for them. For us to have those 2 hours to discuss personal issues, not possible. So I think maybe we should create, in our society, in our communities, whether it is in church or wherever it is, a space where we can actually share, openly, and we assure that information will do what? Will stay there. It will not leak out, to go and to other places.
Very last question on this, as our time winds down, is that, folks think about the last resort like IVF and such, and even the other intrauterine insemination that you spoke about in terms of costs. Is that a crippling factor when it comes to the decision?
Actually, that is one of the things. There is what we call AAA: accessibility, affordability, and availability. When you look at the number of centers where these couples can have help, the numbers are not very many. According to what we call ESHRE is European Society of Human Reproduction and Endocrinology. For every 1 million people, we should have what you call 1,000 cycles of treatment. So in Kenya, let's say if we work with a population of 50 million, we should normally have about 50,000 cycles of treatment. But we don't have that. Why? Again, because availability, accessibility, and affordability. First of all, to put up a treatment center is also quite expensive. The medications that we use for this treatment, all of it, plus the consumables, are all imported. And we can see what the financial bill and other things are doing to this. So it actually puts up the cost of treatment. The other limiting factor could actually be a lack of involvement by the insurance companies. Insurance companies, most of them, it is now some of them to a certain extent are starting, to sort of get involved in this area. Infertility is actually an exclusion sort of criteria, but they forget that infertility is number 5 actually, according to WHO, is number 5 issue when it comes to health issues, affecting a large number of patients. So yes, cost is a factor, and we are trying to work with the different players in this area so that these treatments are available to the patients, let's say in Mandera, Wajir, or Isiolo, Homa Bay, and even in Nairobi, because there's some places whereby this is not available. So we are trying to do that, but I hope the national government as well as the county governments can also come in, support that. I hope SHA can also come in and also do that, because the costs can be prohibitive.
Good conversations to have, and for sharing the information in the way in which you do it. Thank you so much. And of course, these are not situations that you should sit with, but bring them out and talk to folks like you who can actually offer knowledge towards solutions. Dr. Kireki Omanwa is the president of the Kenya Obstetrics and Gynecological Society, has been here with us on World Infertility Awareness Month, and we talked about that today. Thank you so much for being here.
Thank you so much for inviting me.
Until the next time. Good morning. At a minute past 9.